have the next slide. I just want to give credit to my colleagues, Andy Beck, David Hartley, and actually a large team from the Health Collaborative and around the city for the work that I'm going to just share. You go on to the next slide. I'm just going to build a little bit on the example that Craig gave to ground this a little bit more. Craig already mentioned that we live in a region that's spread across 20 states. There's 20 health departments in Hamilton County. Where we live in Cincinnati, there's actually 4 health departments. We have hundreds of congregate care facilities, businesses, neighborhoods. And despite the fact that coordination was part of the regional emergency response playbook, that wasn't the norm. It had been exercised on tabletops. It had never actually been exercised. And we can all remember how challenging it was at the beginning of the pandemic to get information. Some was helpful, some wasn't. Some was pertinent to decisions, some wasn't. There were large delays, manual data entry, misaligned data definitions, and this 21st century pandemic was being tracked with Excel spreadsheets and information faxed to the health department. So if you go to the next slide. So our approach was to actually, we were lucky enough to be able to build on the infrastructure of the Health Collaborative. There were hundreds of decisions that had to be made. Should the convention center be turned into an emergency field hospital? Where should we implement the mass testing sites that Craig talked about? How could non-pharmaceutical interventions be implemented? And leaders from the various sectors were convened in the way that Craig talked about. And when we brought them together, we used an improvement framework of co-designing the goals, the measures, the effectiveness, and the measures of effectiveness and theory of action. And then we sought to make the system visible by a single set of good enough measures. We were leveraging a variety of different existing resources, the Health Exchange, publicly accessible data that we scraped off the web, and disaggregated to appropriate geographies. We started to use the data to encourage prediction. So we put the data to use immediately for the decisions that were being made, working with whoever we could to help fill them in. And we used the data to build shared purpose, to build will, and to overcome some of the competition. Craig mentioned that we started every day with Name That Tune. These were CMOs who never collaborated and were intense competitors. And the reason why the CEO or the COO did that was he wanted to lighten the mood a little bit because it was pretty intense at the beginning of the collaborative. And then last, we encouraged prototyping and unleashing the motivation of various community members and insight and expertise to learn from what we were observing. If you go on to the next slide. And then Craig already showed this. So this is an example of the daily dashboards that we use to coordinate in planning and service delivery. And these dashboards are still updated regularly. You can click on the link at the bottom if you want to see today's. The current incarnations include information on a wide variety of factors: vaccination, incidence, transmission, the R coefficient, the number of patients in hospital and ICU beds, deaths. And when possible and where appropriate, we provided small multiple assessments by age, race, ethnicity, neighborhood, and county. There is a graph in today's deck showing the outcomes by race. And we do that to drive improvement so that members of each system could see themselves as part of the overall system and learn from the data every day. And here in the upper right-hand corner is just a map showing how we use the data to locate testing locations. And at the bottom, we created slide decks to inform, as an example, using the data to inform school planning. We provided decks, some with privileged and confidential information to hospitals and public health departments, and some without. So very aware of the regulatory oversight in which we were using the data. Go on to the last slide. And from these challenges, we saw a variety of guiding principles. First, the data has been so important as a way of bringing people together to see the system for what it is and to inform key decisions that had to be made and to evaluate whether or not the decisions had led to improvement. And that single system view helped to build will and catalyze a networked collaborative approach across the region. Think healthcare systems and skilled nursing facilities seeing themselves as part of the same system. Top-down leadership was sometimes necessary, but it was augmented frequently by bottom-up expertise and action from the community, from various community groups around food, locating food distribution sites, work in schools, and we'll also underscore the term rapid. Rapid system change methods are needed when you're working in a system that changes fast, and testing and learning and ultimately improvement has been aided by the amplification of the lived experience that the stakeholders who are now connected to the data were having. Cincinnati is just one metropolitan area, but we believe that this approach and similar approaches could be applied and adapted elsewhere and for other problems as whether they're future pandemics, disaster resulting from climate change. And what we're working on now together with the Health Collaborative is on using the same system for the epidemic of poverty, racial injustice, and health inequities. And our hope is that from this work that we've done in COVID, we'll emerge stronger and more prepared for what lies ahead.